once the live stream started.
Okay. Right, good morning everybody. Now we have the live stream operating, we'll continue. So welcome to everybody this meeting, including the people who may be watching this meeting via YouTube. Can I ask, so that we can move on with this meeting today, we keep our questions to 5 minutes if possible, so that we can move forward. In this way, it's going to ensure that every member gets a chance to speak before people say they have to go to an afternoon meeting. So we have a welcome to Councillor Kate Fole today and Councillor Anne Callaghan. We'll hear why they're here later, but welcome to both you ladies. And a welcome to Councillor Sam Smith, who's also here for a particular reason, and we'll hear from him later. So, can I accept the minutes, please, as a true and accurate record? Anybody have any issues with them? No. Right, thank you. We'll move on. Martin, have we any apologies? We clearly have.
Yeah, we've had apologies from Councillor Welsh with Councillor Fole substituting, apologies from Councillor McGrath with Councillor Callaghan substituting, and apologies from Councillor Carr with Councillor Hollis substituting, but I think he's a little stuck in traffic slightly, so he'll be here shortly.
Right, okay, so we'll move on. Do we have any disclosable pecuniary interest members to declare, please? Thank you. Nobody has any? Right, you do.
My husband's a community staff nurse.
And my daughter works at QMC. Oh, sorry. Councillor Callaghan.
My daughter-in-law works at Oak Tree Lane School.
Right, thank you. Do members have any private? Oh, sorry.
To be fair, I deserve that by coming late and causing disruption. But no,
Well, of course you have to be here, else we'll
I do.
just go ahead without you.
Punctual, you see, all the other committees run a relaxed system. I know you're strict here, so no, just to declare an interest. My mother is on the NHS pension as a former nurse, and both my sister and brother-in-law are both doctors in local trusts.
Okay, thank you for that. Thank you for that. And private interests. Right, okay. So, good morning to the East Midland Ambulance Service. Welcome to you all. I'm going to let you all introduce yourselves because I'm like Councillor Smith and I can't even see your names. So, and it is my glasses, it isn't the writing. So good morning to you all. It's a little time since you came to speak to us, so we are looking forward to an update and to see how you're going to cope with the winter crisis that obviously, could we say, has happened, because you've already had critical incidents in the hospitals. So over to you, please.
Thank you. Good morning, Chair, and good morning, committee members. And just like to say thank you for inviting us today. I mean it sincerely. It is actually always a pleasure to come and speak and have a conversation with you. And I think that's the important thing for us, that conversation, and understand other people's perspectives and point of view. So we're grateful for that. So I'm Greg Cox, Divisional Director.
Good morning all, I'm Gemma Weissel. I'm the System Delivery Director for Urgent Care at the ICB, and wanted to join the conversation regarding EMAS.
Yes, good morning. I'm Bill Kelly. I'm Head of Operations for EMAS for Notts North area.
Yes, I'm Rachel Bailey. I'm a duty commander at EMAS. Good morning. Good morning.
Good morning.
Good morning. Annette McKenzie, Head of Ops for Nottingham South.
Going to speak.
So I'm going to kick us off, if that's okay. As you as you stated, Chair, thank you. We have got a presentation for yourselves that's based on the brief that we were given around, mainly around performance and what our winter preparations are, and ongoing preparations. I think there were some sub questions to that Noel kindly came back to us, and we've tried to incorporate those in the slide deck. I'll take your lead, Chair, whether you want us to sort of whistle through the slide deck and then take questions afterwards, or whether you want us to take questions. Sure. Okay. I'm happy with that. Okay. Thank you, Chair. That's appreciated. Okay. So our first 5 slides are around our performance. The first slide you see is our category 1 calls. I'll try not to get into ambulance or NHS lingo, but if I do, then please stop me and I will try and explain best as I can. I hope everybody's familiar with the categories of calls that we attend. Our category 1 calls are our immediately life-threatening calls. Mainly these are people who are in cardiac arrest, not breathing, etc., so that they really are in need of serious medical intervention. And the standards for that are 8 minutes and 15 minutes. So you'll see that consistently, certainly on the 90th percentile, so the 15 minutes, Nottinghamshire is only one of 2 divisions within EMAS. Sorry, that's counties to everybody else, divisions to us, that actually achieves the 90th. And on the meantime, whilst we consistently, unfortunately, do not achieve the 8 minutes, as you can see from 7 minutes. Sorry, I'm telling you, I apologise. Sorry, 7 minutes. Keep me right. We are sort of a minute over that. So definitely room for improvement. But I think what it does do, and I take some assurance from that I think in terms of that immediate need to those really serious life-threatening incidents, people are getting a timely response in Nottinghamshire. If I can take us on to the category 2 calls, a little bit more difficult conversation. Again, what you'll see from that around our standards, unfortunately, we don't achieve either of those standards, the 18 minutes or the 40 minutes. I think there is an aberration in there in terms of last December 22. There was, as the Chair described, critical incidents in Nottinghamshire, and the whole system experienced some peaks in pressure, and that affected everybody's performance. But if we accept that particular month is an aberration, what you'll see again is a marginally improving position since sort of last November 22 to our current standards, albeit that we're not achieving either of those times, and they're about 10 minutes adrift on average for both of those. Again, it doesn't necessarily make it better, and there is room for improvement, but again, Nottinghamshire is only one of 2 of 5 counties within the East Midlands that's actually nearly achieving those standards. So it's not exactly a great story, and there is room for improvement. But it is better than a lot of places. If I can move on to, and I know it is a topic that a lot of people do ask us about, so activity performance around turnaround times. Sorry, what I should have said on the first slide, but it's consistent throughout, that actually a lot of people, when they ask about our activity year on year has remained relatively constant. It normally goes up about 4% per year in terms of how many calls or how many incidents we generate. And I think people, quite rightly, I would just make the assumption that because the system is so pressured at the moment, that the actual activity has gone up. Certainly from an ambulance perspective, that's not the case. It's lots of other factors that influence how we handle that activity that's perhaps making the system struggle rather than the activity itself. So in terms of our turnaround performance, now these graphs, I have to say, because we're reporting to the county here today, the cumulative total of turnaround times and lost hours for ambulances at hospitals, but this is the cumulative across the 3 hospitals. So that's Queen's Medical Centre, Kings Mill and Bassett Law Hospital. I think it is worth mentioning, I'm sure it'll come up in the questions. I think we're all very aware that Queen's Medical Centre at the moment is experiencing some significant pressures around ambulance handover. Happy to take more questions at the end, but I can give this committee and the chairs assurance that we are working with our colleagues within the system, both our ICB colleagues and our New Age colleagues, to develop plans to improve that position around us ambulance handover at Queen. Next slide. I was on leave last week. I'd asked this to be changed, and unfortunately, it didn't get changed. It's really, really busy, so I really struggle to try and explain it to you in this presentation. What I will say, was in response to a specific question we got to just sort of allow you some context about how Nottinghamshire EMAS is performing, if you like, in comparison with A, the other counties, and B, within the areas of Nottinghamshire. We usually use, and nationally now, that the main measure we tend to focus on, and nationally our challenge had been put to us, is around our category 2 calls. And I suppose if it's some assurance to most colleagues in the room, I hope it is, that when you then start, if I take you to the orange, so the second section, the category 2, and if we look at the mean, perhaps your Bassett Law areas, Newark and Sherwood, compared with, say, Rushcliffe, Nottingham West, they are all within a frame of being around the same time. So I think hopefully it gives members some assurance that, because I think perhaps I always thought that maybe rural areas suffer with a lesser performance in terms of ambulance response than city areas. I think we've done quite a bit of work, Bill, Annette and I, to try and improve that position, and I hope that's reflected in the figures you see within that. Everybody's happy. I'll hand over to Bill.
Thank you, Greg. So the next slide just lays out what our priorities will be in preparing for winter, and I'll go into more details as we go through the slides, but we're going to cover off maximising resourcing and looking at how we're going to introduce additional staffing and efficiencies. We'll cover off some demand management pieces, which will go through hospital ambulance liaison officers and some pathways, working with system partners, and also obviously importantly our staff welfare that will be ensuring that we implement throughout the winter period. So first on the maximising resourcing slide, which is the next slide. Oh, thank you. We did receive some additional funding for frontline staffing, and we will be adding 25 further frontline colleagues throughout NOTS. Obviously, that's going to be over a period of time, and there'll be training processes in place that we need to implement. But we will say that there is going to be a phased introduction of these additional staff into frontline resourcing, which is obviously always good news to us. We then look to develop and maximise our efficiencies, which will cover off on scene times. We obviously need to ensure that our frontline colleagues are efficient, and obviously need to be supported in that occasion when it comes to looking at the best route for our patients. So we will be having supportive conversations, and we are looking at how to further implement pathways, and as I'll go through that a bit further as we move on when we look at our efficiencies. So, and also we'll be looking at handover times, both pre and post handover through ED. Again, I'll cover that off slightly more as we go through the other slides. But yes, so we also need to look at the reasons behind why there may be delayed post handover times, and that will involve having those conversations with frontline colleagues, but also ensuring that they are supportive of both the EDs and whilst on station as well. Absolutely.
I think just the members and yourself, Chair, by way of explanation, so we're getting, as Bill said, 25 additional staff, and we're busy bringing those through as we speak. However, it wouldn't be appropriate to receive extra staff if they weren't efficient with that workforce, and so I think that's what that slide is trying to describe. That previously, what we've done is done a lot of work on ensuring that we only take patients to hospital that actually need to go to hospital, and where we can, we've looked for other pathways for those patients. But clearly, when crews are doing that does take time. And so I think what that's describing there is a piece of work to work with our colleagues on the road to ensure that they do that and do the right thing for our patients, but do it in a timely manner that ensures they're not staying at people's houses and on scene for extended lengths of time. Thank you, Bill.
Thank you. On to the next slide, please. And this is surrounding demand management. So we'll be introducing NHS Pathways, which this is a new system to us within EMAS. We currently use AMPDS as part of our triage system for taking calls into the control centre, and NHS Pathways has been used by other trusts and has proved extremely successful. So we'll be moving over to that throughout November. There's been a significant amount of training going on with our control room colleagues, which has involved partnership working with other ambulance trusts that currently use those systems as well. So that is absolutely a good news piece, and it should allow a more robust triage of the calls that are coming into our control room. Right place, first time. That's ensuring that our pathways are supportive of the right route for all of our patients, and that crews are encouraged to consider all the pathways available to them. We do have a number of good pathways in NOTS, and we currently only convey around half of our patients anyway into an ED department. So we do effectively utilise pathways within NOTS. We do have a team of specialist paramedics. This team has enhanced wound care, enhanced training end of life care, trauma care. They also have a number of additional medications. They also can do suturing and advanced wound management. They are solo responders, and we have recently moved our North team up into Retford to provide a better pathway, if you like, for the Bassett Law area, and they proved extremely effective and kept extremely busy. We're also going to be looking at how we can see how they can work differently, as in looking at if we can provide them with access to the CAD system remotely from our control room, so that we're able to monitor calls that are coming in that are the sort of Cat 2, Cat 3 grading, and see if they can either provide phone support for those patients or self-deploy to avoid that patient awaiting for a frontline ambulance. We're looking at enhanced winter cell, as I was speaking about earlier on, so we can actually support crews on the ground from a cell that's taken away from our business as usual functions, just to look at are there any appropriate pathways or any other ways that we can increase and enhance that patient journey through the system. We'll also be looking at supporting some of the acute trusts with hospital ambulance liaison officers within the ED departments, and this is to look at how we can again work with partners to try and improve flow, whether that be working with the ED team or consultants. But as I say, that's proved quite effective with increasing flow through the ED department. Also been looking at cohorting where appropriate within the ED departments. Cohorting is where we provide, or there's I'm trying to explain. Sorry.
Yeah, sure. No, that's fine. Sorry, as I say, if we're not careful, we slip into our language, don't we? I think it's just where we in times of escalation, where the acute hospital might be experiencing extended pressure, lots of patients in the departments at once. They clearly struggled from a capacity point of view to take our patients off us in a timely manner. We work closely with them. We've got systems and processes in place where what we do is we'll ask one ambulance crew in the department to support more than one of our patients, and thus being able to release some of our ambulance crews back into the community to patients who haven't got anybody with them. So that's what cohorting means. It just means double enough, if you like, but in a safe and controlled manner that's been planned in advance.
Thanks, Greg. Yes.
I'll pick up this slide. Okay. So as Bill's already alluded to, we have the new triage system in our control room, and one of the benefits and one of the reasons that that's been implemented, it's more, I'm not sure what phrase to use, it's actually more intuitive in terms of triaging patients. The previous model, which was an internationally renowned triage model, the AMPDS, an American developed model, was quite blunt in how it categorized patients and their illnesses and didn't dig in underneath to the detail. Pathways does, and what therefore that allows you to do is that you are able to have a greater intelligence and an understanding of what an individual patient's condition is, and therefore if you've got that better understanding, you're better able to direct them to the right care for them. So that's what that's talking about, that we're working with our control room and community providers to ensure that those patients get that care in the most appropriate way for their needs. So I think that's what says in that. And two, the system, and this isn't ours, the Urgent Care Coordination Hub, this isn't an EMAS initiative, that's within the my ICB colleagues have very kindly championed that, but we mention it here because we welcome it as an ambulance trust. It's absolutely invaluable for us in terms of what's previously happened. Systems with the best of intent invent lots of different phone numbers for us to ring to get help, and that can be very confusing for our colleagues on the ambulances. What this does is basically give us a single point of contact, so that any issue where we think we've got a patient that doesn't need to go to an ED, we can call this Urgent Care Coordination Hub. So I'm absolutely excited about that. It's still early days, but one we're working with our ICB colleagues to really develop and really take advantage of. Similarly, I know Bill manages the Bassett Law area, but they've also developed a primary care hub. And we developed a really good relationship with our primary care colleagues, excuse me, in Bassett Law, and we've sort of opened up those channels for our crews to access that as well. Okay, thank you. Next slide.
Thanks, Greg. And importantly, onto our staff welfare and keeping our people safe and happy at work. Last year's flu vaccination programme, we achieved 89.4% of our staff, and 100% of staff were approached and offered that vaccination. I don't know the exact figures today, but I know that we certainly we're halfway towards that when I looked yesterday. We also work with our staff closely so that those that do have individual needs do have the opportunity to work flexibly. We obviously need to pair that with providing a frontline resource, but we do work really closely with our teams just to see that where we can support flexible working, we do. And as you can see, that so 23% of our staff currently do work flexibly, and I currently sit on the working group to look at how, as a trust, we can improve flexible working further for our frontline colleagues. We're going to introduce our welfare support vehicles again at ED. These have now been delivered to our stations, and they will provide somewhere warm, hot drinks and chat and peer support for colleagues whilst we go through the cold periods. We're also doing a piece of work at the moment where we're speaking with our teams just to understand the reasons behind the sickness absences, and if there is anything that we can do to support colleagues maintaining their attendance at work. And there will always be various local individual circumstances and concerns, and we are looking at addressing those and say, if there are any other bigger pieces of work, any other support mechanisms that are additional to what we already do, for example, Mind Caddy, and we do have a lot of support out there for our colleagues. I would say, but it's still about asking the question, is there anything else that we can do to help you? I won't go through the individual figures as they speak for themselves with regards to staff retention. And then moving on to the last slide, this goes through the main reasons for sickness absence throughout, and understandably, what is of concern is the highest reason of anxiety, stress, and depression. So we are doing a lot of work with our frontline colleagues at the moment, just to understand the pressures and to understand the reasons behind that. I will say that the majority is not work related stress, but we need to take into account that all of these sort of situations that people find themselves at home at the moment with the energy crisis, etc., also affects colleagues that run frontline ambulances. So it's about understanding how we can support them in different ways. But we are absolutely working with those, specifically with the anxiety, stress, and depression, just to ensure that we can support them and do support them throughout where we can.
Thank you, Chair.
It up to everybody. It's maybe a very basic question. Can you explain how you're more or less managing to get there in the category 1 in the emergency, getting there in 7 minutes or 15 minutes, whatever it was, but you're not able to make the timings on the next category? Why is that? Is it because it's to do with handover?
Yeah, no, it's a good question, and there isn't one simple answer to it. And I think there is a point around we do ring fence or hold some resources, just mainly cars, to respond to category 1 patients, acknowledging that if somebody's in a cardiac arrest or not breathing, we need to be there very quickly. So I think that's the main reason we hold resources aside for that. Not many, I have to say, because actually a category 2 patient is, as an example, is somebody having a heart attack is classed as a category 2 patient, but I think we'd all agree still needs an ambulance very, very quickly. So we aren't able to hold many resources. Certainly, again, our acute colleagues will work with us on that, and where we might be experiencing handover delays, but if then a category 1 call comes in, they'll make best efforts to release a crew for us so we can get off onto that job. Also, there is something around how our control rooms work in terms of priorities in jobs. So it's not ideal, but I'm afraid it's the decisions that have to be made on a daily basis. So if an ambulance has been deployed to, say, a category 3 call, somebody with abdominal pains, etc., and a cardiac arrest comes in and they're still mobile, if it's appropriate and they're in the vicinity, they will be redirected to that more serious call. So that's probably the main reason.
I thought that was probably going to be the answer, but that's fine. Thank you. Councillor Holt.
Right, thank you. First to say thank you. I mean, I think anybody listening to this that wasn't aware of the breadth
and the creativity of the work that you do. I think it's amazing. So thank you very much. We all understand that you're working in very difficult circumstances for a whole range of reasons. So just to say that first, so just to say thank you. Okay, in terms of response times, I think I was going to ask a similar question to the chair, but around response times, because some of them clearly they are worrying, aren't they? And I know they will worry you. I'm not telling you anything you don't know. One of the things that people said to me when I said I was coming to this committee meeting was tell them about the people queuing in corridors to get through A&E, because as I understand it, there's at least one or possibly two paramedics from an ambulance with each bed, and clearly that is actually kind of preventing your is reducing your capacity to get back out there again, isn't it, when there's another call coming in. So we're really interested to know if that is a thing, or whether I know this is anecdotal, but whether that's measured, and if so, if you could kind of hear what impact that's having. In terms of winter pressures, I was just going to ask about winter pressures, because if you look at these figures in terms of activity and performance, and actually there's a thread running through, November, December leaps out at you, doesn't it? As actually there's an issue here. But when we had a look at your business plan, we couldn't see any kind of planning attached to that. We just wonder why that is, or if there's a specific reason why it's not kind of planned for, or whether they just simply don't have any more resources so you can't plan for it. So that would be a really interesting one. You mentioned again in kind of your presentation, you said about the system is so pressured, and it would be really interesting for us to hear what the pressures are. You said there is context and influencing factors here. What is it that's making it very difficult for you to deliver the kind of service to as many people as possible, as quickly as possible, that you're not getting? You mentioned you had 25 new staff. Is that enough? I'd be interested in actually what your overall kind of staff cohort is, because on the staff absence summary, you've got, I think that's hours, is that unit down the side in terms of missed, and it tells you kind of in terms of some of the numbers in terms of staff leaving and all the rest of it. What is your overall staff cohort? So what is that as in terms of stress and anxiety? What is that as a percentage of your overall overall staffing cohort? Okay. I think as well in terms of staff welfare, I mean, we all understand people are under pressure. I mean, people in the public sector across the board, people working for this county, they're not paid particularly well. They're under an awful lot of pressure because of the cost of living crisis, and that is impacting very badly, I'm sure, isn't it, across the piece really. It was just interesting to know how that's impacting, and how actually, and whether or not the pressure of work and the kinds of things they're seeing, the kind of pressure they're under when they come to work, how that kind of separated out, how that is actually impacting on some of your kind of really hard-working staff, because staff welfare is key here, isn't it? And you are your staff, and they're the ones that can deliver the service and do this brilliant job. So if we can understand a little bit better what it is that's actually both preventing recruitment and retention, because we know that's an issue across the public sector, but also what perhaps we could do to help them, to help you, to actually help them deliver a better service. But thank you.
Have you got a list?
Yes, I've made a list, but I'm looking at Annette Bill to finally chime in and help me out with this one. Yeah, I think the first point you raised was actually somebody's brought to your attention around the queuing in hospitals and therefore seeing multiple ambulance staff. What would perhaps apparently be just hanging around, I suppose, when people in the community need those ambulance colleagues. And to some degree, we've acknowledged that, and the work I described that we're currently doing with our ICB and acute colleagues is trying to address that to some degree. So, as I think I described, around what we call cohorting. So, as I say, it certainly happens. We can predict days of the week. Mondays is often a day when we experience that pressure. And what happens is you'll get that sort of 11 o'clock surge in the morning, and then that rises and goes throughout the afternoon. And so that I think there's just that on the day pressure that an acute hospital can suffer, that means that their staffing to try and cope with that peak becomes challenged. And so we get this backlog of ambulances. Nottinghamshire hospitals have been pretty good at getting our ambulance patients in the department. Other hospitals in other counties, we have seen, I think, all on the news, pictures of ambulances with patients on the back of them queued outside. the A&E department. As happened sometimes recently at Queen's, that I think I've been honest and open enough to acknowledge that happens. But generally speaking, Nottinghamshire Hospital are very good at getting us into the department. I think what you're describing there is then comes the difficulty about the hospital's ability to actually physically take that patient off us. That's where we try and work with the hospitals, and what happens is we effectively continue that care of those patients until the hospital can effectively take the patient off us. What that does mean, you're quite right, is that you've an ambulance crew with 2 people, and so there's 2 patients, 1 patient. So what we're trying to do is say, well, can those 2 people say look after 4 patients while that happens, and therefore release some of those crews. So it does seem a waste of resource. We are trying to do something about it as a system. But as I say, there's that balance to be had, because it's always about ensuring that the patient is safe through that, but also acknowledging that the patient isn't safe who's waiting for an ambulance in the community and hasn't got one, is it? So it's just trying to find that balance. I hope that sort of answers that particular one. Yeah, okay. Winter planning. Yes, I'm sorry it's perhaps not evident in the trust plans as such. We do, I can absolutely assure you, recognise year on year those winter pressures. Although I will be honest and say, I think it wouldn't be any surprise to anybody that the traditional winter pressure is not necessarily so more anymore, and that it's a constant pressure throughout the year. I think is what we're now living with, is the reality of what we live with. However, we do still plan for winter. I think because we're probably most of the year running with a maximum resource, and I'll come on to that because that was one of the other questions. Our maximum resource, it's very, you would think, well, we'll just put more on in the winter. We try to do that, but that does have to be through overtime, etc., because we just haven't got any more planned resource to put out. We will do things, we'll work with about particular events. We might work with St John colleagues to put on specific places in the town centre for certain events. And in terms of what does that look like, so just to give you some context around the staffing. So the division, or the county, sorry, Nottinghamshire County, has circa, and I say circa because with attrition it can vary month on month, obviously, but we're established for 530 frontline staff, which means we can put out round about our maximum output on any given day, and it varies by hour of the day as well. But in Nottinghamshire, it's not as many as you might think. We put out a maximum of about 55 to 60 frontline ambulances across the whole of Nottinghamshire. So it's not a lot. In all honesty, it is. In terms of if everything else was being equal, and I'm trying to be as honest and frank as I can on that. I always commit to giving some honest answers here, and it genuinely is. I think that there's lots of people far more qualified than I am to have understood those statistics and absolutely assure us that that is the right amount, and that's why we're funded to that level. It's about everything else being equal. Hospital pressures, other systems. You would be maybe surprised how being part of a regional ambulance service, what's happening in other health systems affects flow in our system. So that becomes part of the problem. Happy to mention, and Barmer's chipping Bill, we did, I mean, don't be getting an extra question here, but we did in August, I believe it was, we tried to do what we called a perfect day, where we said, okay, let's try and make everything else equal and see could we perform. So we maximised our resource output. We spoke to the hospital and said, can you sort of really support us, turn our ambulances around quickly, etc. We did a few more things about focusing our efforts, etc. Work with our control room colleagues. And on that day, for that 12-hour period, we did achieve our national standards. So it can be done. I'm in danger of I'll preempt the next question is, well, why don't you do that all the time? Unfortunately, I wish we could. It is just about being able to consistently influence all those other factors that is not as straightforward as we might imagine. But as I say, it does give us the focus that it can be done. So there's something to work towards. So I think you said, and I might look to my ICB colleague here around, you asked about what are those pressures that we refer to in the system as opposed to just EMAS. I don't know if you want to comment. It's difficult for me. I don't want to necessarily comment on behalf of our acute colleagues, but I don't think it's necessarily a secret to anybody that they experience, I think, flow problems throughout the hospital and through discharge, etc. Is that fair to say, Gemma? I think, and therefore that sort of backlogs to the front door. So I think that's one of the issues we're trying to deal with. I think again we're all very aware that our primary care colleagues are absolutely inundated as well, and so people, I think, naturally we become that default position when everything else fails with sort of ring for an ambulance. So that's probably the sort of pressures I was referring to. Anything else? Yeah.
Do you need to add anything, Gemma?
I think just to make a comment, I think what we see in the pressures in the ambulance service is symptomatic of actually what's happening everywhere else throughout the whole system. You know, we're seeing a higher demand, as Greg said, in primary care, but also in our community services. And we've obviously got an ageing population, and we're seeing people with higher acuity going into the system, but also coming out at the other end, people living longer with lots of multiple long-term conditions. So we have a greater demand across the whole health and care system. And I think certainly, you know, you'll be very aware of the social care pressures and the higher complexity of packages coming through. I think that's symptomatic of everywhere through the health and care system. But unfortunately, our EMAS colleagues see that at the more acute end when people are needing a hospital. But it's the sustained pressure that we've got throughout all of our health and care services. So I think this is a reflection of that we see in the ambulance performance.
Thank you. I'm sure you wish for more perfect days. Perhaps you can have 2 perfect days a week.
Yeah, absolutely. I mean, we do plan to do it again. And yes, it would be good to have 7 perfect days, wouldn't it? Absolutely would. And there was one final point that you made on around our staff welfare. Billy, you're happy to sort of, Bill and Annette, I suppose, manage the north and the south of our county, so they're a little bit closer to those staff issues than I am. So Bill and Annette are happy to sort of.
So I covered slightly earlier on about the welfare vehicles, about supporting colleagues at the acutes outside ED. But there are quite a few pieces of work that we're doing internally as well. So I noticed your sign downstairs with the Armed Forces Covenant. We are currently silver within EMAS for that, and currently working towards our gold level. And I'm one of the champions that are working towards that. So what we're doing is to ensure that individual support is there as well for colleagues that have come from armed forces. On top of that, as I say, we've got our mental health support tools with Mind Caddy, with various counselling and therapy. It's also about myself and Annette and the team being very visible and understanding what people's individual concerns are as well. And if it's just that one opportunity to say, you know what, we genuinely think that if you could implement this, it would be a far better place to work. So it's about that listening piece. So we have Station Voice, who are a group of people that we meet with regularly, just so that we can get that background, if you like, and that on the ground experience from colleagues, and they come to us and say, could we implement this, or there are these issues, can we please help resolve this? We have very close relationships with our union colleagues as well, again, to look at how we can implement any sort of improvement. So there's a lot of work and various pieces of work streams going on to help us support frontline colleagues as best as we can, as I say. And a lot of that anxiety and stress absence at the moment is down to those same experiences that other people experience, as in we said, with energy bills and cost of living. So it's about ensuring that support is there, and even if it's that listening piece, or can we adapt flexible working to cut down travelling, etc. Just what ways can we help people? It's about that listening piece. It's about us being visible and available, and where we can, just making those small changes that makes that bigger, better experience for that frontline colleague. If that makes sense.
Thank you. Councillor Hollis.
Thank you, Chairman. And I can't promise not to take up as much time as my colleague, Councillor Fowler. I think she's asked some of the questions already that I wish to ask, but I still have a few left. But I think before I do, I think it's probably a good opportunity to probably might humanise it a little bit. If I can put my personal hat on rather than my council hat on first. Unfortunately, my family's had the need to use your services very much recently, and sadly lost a few members of the family through to ill age and health problems. But certainly some of the stuff I see from residents I've seen personally as well. But I think positively, you saved my father-in-law's life. Without EMAS and the colleagues who responded very quickly to a heart attack and got him to the hospital on time, despite 2 cardiac arrests on the journey, we were able to save his life, and he's still with us here today, a year on. And we've been able. He came to our marriage in August, walked my wife down the aisle, all stuff that he wouldn't have been there to see, but also I think helped him in his rehabilitation process. But without the ambulance service, he wouldn't have been there, and that was very clear. So I wanted to thank you on a personal level for that, and you know, it means a hell of a lot to me and my family, particularly. But then obviously on the flip side, I think for my grandparents particularly, who I appreciate probably weren't an urgent case compared to others, and probably slip into the category 2 and lesser sections. We've faced some of the tougher times where we've had to even take them down in their own vehicles when having head injuries, etc. So I think we've kind of experienced the full array of the challenges you face. But that's not a criticism of you guys. I think it's ultimately the pressures I think we all face. So I think just to install my councillor hat back on, I just want to turn to some of the questions that we've got. So obviously one of the biggest issues residents face in Nottinghamshire is the state of our highways and the damage to their vehicles because of the broken roads. Do we have any figures on the impact of potholes on ambulances, and how many ambulances were taken off the road in Nottinghamshire and the wider region? And if so, for how many days due to damage caused by potholes? And then, of course, according to a Freedom of Information request published on Sky News, a wait for a Category 2 incident in the East Midlands was more than 26 hours in December, the longest wait in the UK for such serious symptoms. My question is can residents really trust that an ambulance will reach them in an emergency? And then finally, we have incidents where stroke and heart attack victims are left waiting for hours when every second counts. Is this a resource or a process issue? Thank you.
Greggy, you going to answer that one?
Thank you, Chair. Thank you, Councillor. First of all, obviously, sorry for any losses you've had within your family. Please accept our condolences, and I am pleased that you were also able to say that there was some good news within that with your father-in-law, and I'm pleased he's clearly up and about again. So that's a really good news story, and I think actually what you've done there is very encapsulate the whole story of perhaps the NHS and the ambulance service, in that it really can be one of two stories, can't it? And it can either be a very nice, heartwarming story that we're all pleased to hear, and it can also be an extremely tragic story for any of us. Losing loved ones is not something any of us want to do, so certainly not through reasons that potentially could have been avoided, but through timely response. So we're very mindful of our obligations and our responsibilities, and take it seriously what it means to our patients. I think it is worth mentioning that myself, Bill, Rachel, and Annette are all previous road colleagues. We're all clinicians ourselves, albeit very rusty these days, but we have all been on the road and experienced it, and the happiness and sadness that comes on a daily basis. So it's not worth, don't want to underplay what you described. I think it's really important. Won't do very well on the first one. In terms of potholes, I certainly haven't got any information regarding whether it's damaging ambulances. And normally with these, I could perhaps commit through Noel to take something away to do this research. I'll ask the question, but I'll be perfectly frank with it and say, I don't think we'll know, but I will certainly, we have a fleet department and they may monitor such a thing. So whether there's can spot an increase in suspension issues for vehicles, for instance, I can certainly commit to taking that question away if that's, you're happy with that response. I think your second one was C2. I think your second and third were really on a similar vein around confidence in the public, having confidence in the ambulance service to respond in a timely manner. And you certainly gave, I mentioned it also, that worst example of last December when things were clearly broken for a while there. In terms of me looking you in the eye, because that's how I'd like to do it and give you confidence, I mean it with some sincerity that I think from the people in this room, you've got an absolute commitment that myself and every single one of those 530 staff that work with us are doing everything our level best to give you that confidence that you'll receive an ambulance in a timely manner. I think you've described that when everything else is equal within that system, we can do it and we can respond in a timely manner. And it's not the right answer, the necessary answer you want to hear, but I think it's often those other influences that are outside our immediate control that prevent us responding to your timely manner rather than our own ability to do so. And probably that then informed me, answers your last point was, have we got enough staff? I think to your previous colleague, I answered that quite directly and said, bizarrely, yeah, I think most people are surprised when I say yes. I think most people expect me to say, oh, no, we need more. I genuinely don't think we do. I think there are other issues that if we resolve the other issues, we would have the right amount of staff. I hope that's answered your questions.
Thank you very much. So I suppose my follow-up question is very similar to Councillor Hollis in terms of category 2. I think you've answered the questions on category 1 responses quite well, in the sense that it's very much a case of get as quickly as possible. So I've had a look through the previous reports you've given to this committee from 2021, and I know you mentioned about this new approach, and I can see in the reports themselves, you can see the distinct change in response, especially the focus on pathways. So as part of looking through the response for the previous reports, I was also looking at the response times of these previous reports. Now, as you can imagine, 20 to 21, you was in COVID as well. So I suspect when I say to you that the response times for back then were significantly better than the ones now, you're not too surprised. So category 2 mean it was 20 minutes or 20 minutes 42 seconds, which is only 2 minutes over the target, which you would say, yes, that's work on the right track. But obviously that has deteriorated for the past 2 years, where we are now on a mean response rate in category 2 in knots 43 minutes or 44 minutes. Now category 2, as I understand it, is for a serious condition such as a stroke or chest pain, which may require rapid assessment. Now, I suppose in terms of the competence issue, I suppose when a resident calls up the ambulance and they get a response saying, okay, we won't be there in 20 minutes, we'll be there, let's say, 40 minutes. I suppose the question in terms of competence is always, for someone on the phone, they're looking around going, okay, the hospital's 20 minutes away, do I wait for this ambulance or do I just go myself? Now that's not a situation anyone wants to be in. I suppose in your case, you've got this increasing response rates. I know we've talked about the flow, things like that, but in terms of those residents, what would you say to those residents? Would it be better for them to just get on in the car and go to the hospital? Would they be seen quicker, or is it a case that they should sit back and wait for the ambulance? I know you can't give a categorical response based on the circumstances, but that's almost the way the residents are feeling at the moment with the ambulance service. Obviously, in terms of this category, that's a stroke. Now, obviously, category 3, 4, residents aren't clinicians. They don't know if they need an ambulance or not. So their question is always, do I even bother with the ambulance? Do I just go there myself? And that's, again, I think it follows through what Councillor Hollis is point about competence. If I know if an ambulance on the way, I have full confidence they're trying to get there as quickly as possible. They're trying to see them as quickly as possible. But if they're not going to get to the hospital in a faster manner, what do they do? I suppose if you're able to open up on that one.
Yeah, certainly. Quite a tough one to answer, but I'll do my best. And as I say, I will do it as openly, as candidly as I can in terms of what that response looks like. I think, as I say, I've already partially answered it. In terms of your direct question, if you're asking me, what would I say to those people? Should they take themselves to hospital or wait for an ambulance? As you say, each case is different, so it'd be very difficult for me to comment. But as a general rule, if somebody has considered themselves or a relative or friend poorly enough to have rung 999 in the first place, my instinct tells me is to wait for that ambulance and that specialist care that will arrive. And bear in mind, when you ring 999, we are the best ambulance trust in the country in our timeliness to answer calls. So even if you haven't got an ambulance, you are immediately connected to some form of support. And I haven't mentioned it because it's not within our normal sphere of influence, but within our control rooms, we do have a number of clinicians, nurses, doctors, etc. So we do have an ability to support people in the community who need that help. We also work with our system partners, so there are other ways we can direct some of those patients if it seems appropriate that actually, yes, you wrote 999 for support, but you know what, we think we can get you a more timely response in a different way. So I would always probably encourage people to take that rather than take matter into their own hands. In terms of, sorry, I think I've lost my thread a little bit here, but I think in terms of that confidence, I think we are working hard. I think, as I mentioned a couple of times, we acknowledged the last December problem. I think we're far more focused because of that, if you like, in terms of a system about what we do about that. Jim and I and other colleagues have been working really hard to ensure that our current situation around turning around ambulances, etc., will improve. I'm not sure I've answered all. Sorry, just remind me.
Yes, that's fair. Started quite in terms of the increase in response times. So we started off at 20 minutes in 2021, the end of 2021. We're now roughly about 43 minutes. So if you're category 2, stroke, that's 40 minutes you're waiting. Not ideal. So I was wondering, what's the blockage? Is it the flow through at the hospitals, or is it something more with EMAS?
Again, I don't think there's any one single factor to that, but if you want me to try and sum it up into what the contributory factors are, yes, there are that I think we've all acknowledged, and I won't want to speak for NUH as an organisation, but I think we all acknowledge they have struggled a little bit of late, and those turnaround times have changed, and that has influenced our slightly worsening position, because if we are at hospitals, we're not out there responding. I did touch on earlier around other the counties and their health systems, and you'd be surprised how much that does influence the flow of ambulances in a regional service. It sucks you in. I can give you some very real examples. If we got spare ambulances in Newark and there's an extremely poorly patient in Grantham, is it right morally for us to sit there and do nothing when there's a patient so near? But that then by nature does draw that ambulance out of the Nottinghamshire area. I think from a moral perspective, we would all agree it's the right thing to do, but it creates that flow problem. Then the ambulance perhaps goes to Lincoln County, etc., etc. So we get this almost vortex of ambulance flow that gives us some real problems. And going back to that perfect day, we managed to a large degree to prevent that happening, and that certainly, so you tell how much it influences it. So it is those, I think, system pressures, as Gemma also described, that's at every level. So at primary care level, our community services are struggling, and I think it is. I think that before patients ever get to us, I think if they're struggling to access those services, that might prevent them from calling us. As I think I said to you, often patients in that last resort will think, well, I'll ring for an ambulance, and you know, it's not ideal, is it? And there's a lot of work to ensure that we make things better for people to access that right care first time. But hey, as an ambulance clinician, I am pleased that whilst not hitting the national standards, people in our communities do feel that at least they've got one place they can go that's always open, if you like, and turn on us, or turn to us, I should say, not turn on us. But I hope that helps a little bit. It's not a perfect question, but I haven't got that golden nugget for you, I suppose, if I'm honest.
Like I said that before I come on, because it's like I'm going to ramble. Right. Yeah, all right, yeah, okay. Thank you very much for the presentation. It's great. There's a few constructive things I'd like to say, because we know you do an amazing job, and and that's always reflected by the fact that staff come. It's always staff that come from EMAS. It's always people who've been on the ground and know the job, and that's the best thing about it, because you know what you're doing. You know how to deal with people. Along at the same time, you know, I'm not going to dwell on the ambulance response times, because I think you do very well to pick people up from Newark as the same time frame as you do people in the far reaches of Ashfield and Mansfield. There's very little in it, and we all know that you do the best you can to get wherever you can as soon as you can at the right time. And I think some of the failings on the staff all throughout the system are where you arrive with your patients. And I know Kingsmill is particularly good at it. I met Paul Robinson at Newark Shield at Kingsmill, and they've got a good system at Kingsmill, right? And I wish that was reflected upon in other counties, because it's what we're not hearing in this room today is that EMAS deal with 5 or 6 counties and not just Nottinghamshire, and the impact on what happens in other counties is having an adverse effect on that, particularly Grantham, Lincoln, Newark, you know, and Leicestershire. We won't go there because that's even worse, right? So, you know, I mean, there were 14,800 hours were lost due to waiting times last year, and that's 4,000 more than the year before. And I don't think that's a reflection on Nottinghamshire hospitals, with the exception of NUH and Queen's, and that's got its own particular acute problems, which I'm glad we created the ICB some 6, 7, 8 years ago, because the ICB are the right tool, the right vehicle, should I say, to get that problem resolved. And yes, it is to do with discharge to assess, but I do find it particularly sad that we're having to use ambulances and move patients out of one ambulance into another with other people, because I've got, it's a good idea, don't get me wrong, I'm not calling you for it, I think it's great, because the greatest anxiety level for paramedics and first responders is obviously not being able to get back out there, and sitting around waiting at an A&E department is the most frustrating thing, even if you're a patient or a parent with somebody. So for staff who know for a fact that people have got cardiac or they're injured or they could be a road traffic accident or whatever, and they're sat there waiting to hand people over, has got to be the greatest impact on stress for staff, and that concerns me more than anything. So through the ICB, I would really like to see concentration on pathways for releasing those ambulances, especially at places where it's not so good. And I think we ought to write to our colleagues in Leicestershire and in Grantham, Lincolnshire, right, and say to them, come on, get your act together, because that's part of the pressure. He just actually said, if I had to send an ambulance from Newark, which takes 55 minutes to get to Kingsmill on average to transfer a patient, that's a statistic from last year. So, that would be a real bonus if our integrated care board could talk to the other counties around us and help EMAS, because right from Bassetlaw, which is Yorkshire Ambulance Service, through to Leicestershire, and it's a joined up thinking approach that we need, because the NHS areas and the EMAS areas and the Yorkshire Ambulance Service areas cross over each other, and they're governed by different bodies, and nobody's actually talking to the other one, I don't think. And I think that would help the staff greatly, because I do think, like I said before, I do think it's a great idea to have 3 or 4 patients in an ambulance, but that's going to bring a whole other set of problems, especially in winter, as you know. So if you could just answer me one question or expand on it. What's your enhanced winter cells? Is that what you're talking about at the ambulance? Is that what you're actually talking about? And of course, obviously, how are you going to manage the safety of the staff when you've got more than one patient in an ambulance? Because it's not really a very big space,
Thanks, Chair. So firstly, just to clarify, we don't put more than one patient on an ambulance. So we wouldn't cohort on one ambulance and have 2 or 3 patients at the same time. What we would do is to work with the acute trust to find a space inside the ED where we could then manage those patients. So we wouldn't have them all back of one ambulance.
Right.
So yeah, we absolutely would ensure that a patient's respect, dignity, and privacy is absolute paramount. The efficiency cell is basically a centralised function within NOTS that we take away from our daily business, if you like. So basically, it will look at what flow through hospitals are. It will look at what held calls we've got. It will look at would those patients benefit from a callback, or do they require an ambulance? It will look at ambulances currently on scene with patients. Is an appropriate pathway that we can be using? Are the crews aware of that pathway? Do they need support or assistance with any GP callbacks, etc.? And it will also look at any sort of blockages, if there are any, sort of with any flow across the system, that actually they might suggest that a crew could consider using as a other pathway or an appropriate ED that's maybe not the one that's right next door to them, sort of thing. We're not keen on taking people out of area, don't get me wrong, but if we're on the border sometimes and we might find that there's a better patient experience at that time, if they were to go to that other hospital, we might suggest that. But that cell will look at all the variables, and it just takes that, or it gives the crews on scene that support. Because sometimes you get quite focused and rightly on your patient, and it just gives that other bit of understanding or any other ideas or input that the crew might benefit from.
Right.
Thank you. First of all, just want to commend you for actually highlighting staff welfare. I don't hear it very often from other trusts when they come to give this type of feedback, so that's really good, and I know it's something that you've worked really hard on over the years. Waiting times I know are an issue, and I guess what we've already heard around what the ICB is doing to facilitate that joined up thinking is really important. What I'd like to sort of highlight is the use of paramedics. Health Watch is, I'm from Health Watch, sorry, we're starting to get more and more people contacting us about the length of time they've waited for an ambulance and also waited at particularly QMC. We don't hear so much about the other hospitals, as you've explained. One example was a 91-year-old who'd fallen, was on the floor, relative didn't want to lift, was triaged to get the paramedic. That was a 9-hour wait. When they didn't come, they finally managed to get them into a vehicle, got them to QMC, where they had a 12-hour wait at QMC. So this is a 91-year-old in that position. And I know in care homes where they're safe, but you can't actually take somebody off the floor in a care home, so somebody could be laying on the floor for quite a long time if they've fallen. Within your statistics that you've given us, I'm assuming this doesn't include the paramedic waiting time. Is that seen as a different metric than an ambulance? And what can we do to improve? It's using the use of paramedics to mitigate some of the issues with ambulance wait times. But then if we've got wait times for paramedics, I'd like to understand what those issues are. Thank you.
Thank you. I think it is all wrapped up in the same issue. By way of explanation in terms of statistics, so the ambulance response times are effectively a paramedic response time, because hopefully, not on all ambulances, but on most ambulances where we've got them, we will obviously put a paramedic on that vehicle. Certainly in terms of the case that you described, that's extremely sad, isn't it? I don't think, imagine anybody in this room would support that position where any person of any age who requires an ambulance has to wait 9 hours and then 12 hours in the A&E department. And certainly from an ambulance perspective, we can only apologise for that. We wouldn't want that to happen. We absolutely don't want that to happen. I agree with you, and I think your point, forgive me if I'm wrong, but I think one of the points you're making is it right that we're then using paramedics in A&E department to then support the care in an A&E department rather than what they should be doing, which is responding? And again, Jim, I know will agree with me that, quite frankly, no. If we can find other ways so that other people can care for those patients in an ED department and release our paramedics, that is our ambition.
Sorry, that wasn't the point. The paramedic didn't come. And they took the person to the hospital themselves because they waited so long for the paramedic. And this is one of these standalone single car paramedics, not one that's in a bus. So I think that's the point. I think I've understood is that one of the mitigations is to have teams paramedics in the field who can attend rather than an ambulance. And that's what they were offered. And I'm just wondering if that's a different service to the ambulance, if you see what I mean, because you put it in your report that you've got those types of responders.
That's those paramedics. Yeah. Sorry. No. We have, but they are deployed in the same way as a double ambulance crew. So just by way of explanation, as you would imagine, all our calls come into our ambulance control centres. We've two. We've one at Lincoln and one at Nottinghamshire. Every single 999 call comes into those two centres, and the trained and qualified people in those centres have all those calls on a stack, we call it, and based on the code set that emergency through triage generates, that then prioritises who gets that response. Those paramedics, even though they're in cars, would still be deployed to emergencies. I wouldn't want to speculate why we might have had a paramedic spare and yet leave somebody on the floor. It's not what I would expect. I can't comment on that particular one, but I would absolutely expect where we have calls waiting and we've got paramedics available, we would deploy them. Sorry, it probably doesn't ideally answer your question, but we do maximise all our resources wherever possible. I know I previously described that for category 1s, we try to hold cars back for that, but given that length of time, I would have expected somebody to have gone and attended to that patient, which is, as I say, just a really sad case, isn't it?
Thank you, Greg. Councillor Anderson.
Thank you, Chairman. Patient flow has been identified as a key priority for NUH. Has EMAS noticed improved flow in 2023? And if so, what areas requiring improvement remain from the EMAS perspective? Just building on what you've said about patient flow, what work are EMAS and the Integrated Care Board doing about the social care sector to arrange care plans quicker, keeping the back door flowing, so empty beds, and improve the front door flows for ambulances? Thank you.
Thank you. If I may, I'll just follow on. I'll probably start to answer that question, but then perhaps ask Gemma if she can pick that up for me. In terms of flow that we experience at that front door for our acutes, as already been described, I think we all know that within the Midlands region, Kingsmill, it has to be noted, is one of the best hospitals for taking ambulance handover, and we thank them for that. The Bassett Law position has improved in 2023. I think we've done a lot of work, Bill has, certainly in terms of liaising with colleagues at Bassett Law to improve that. I know they've got a lot of construction work going on at the moment that we've worked through with them as well, and they've maintained reasonably good handover. I think, to be fair to Bassett Law, it's a fairly small department, and it doesn't take much in terms of physical capacity to experience some difficulties. But again, we work with them and have plans in place to mitigate that. I think the bigger issue in terms of flow, I'm going to pass it up, in terms of perhaps is being experienced at NUH. So as for
thank you. So actively now we're working together with EMAS and NUH to develop a plan around how we improve that ambulance position at the front door. But absolutely, as you recognise, flow is also affected at the back door of the hospital. And what we do have now is we've got transfer of care hubs live at Sherwood, at NUH and at Bassett Law, and social care are actively involved in that. So we have social workers present in the hubs to work together on restarting packages of care. And now they've only been in operation for the last few months, and we've also just started to move to 6-day working, because we recognise that we don't want discharges to stop at the weekend. But they are making a real difference at how quickly we can get people out of hospital. So we've seen speed times improve in terms of packages of care, getting people home, getting the person to the right bed at the right time as quickly as possible. But there's absolutely more to do. So I think, my role in the ICB is looking at how I can support EMAS and the acute trust on speeding up that front door time. But rest assured, there is a whole programme of work around discharge and the back door as well, and the acute responsibility inside the hospital as well. So there's internal transformation programmes within our acutes actively now looking at how do they speed up that flow through the hospital and get people that are safe to be in their place of residence home as quickly as possible. So absolutely, as part of the ICB, we have an overview of the whole pathway. But yeah, conscious that we're here to talk EMAS today, but there is programmes of work happening at both ends of the pathway to try and improve and speed up efficiency.
Thank you. Vice Chairman.
Thank you. Just looking at the daily lost hours, I think, Greg, you said there's about 55 to 60 ambulances working daily. And then if you look at that graph, it looks that about between 40 and 60 hours are lost. So that basically equates to an hour per ambulance daily. And then obviously in December that goes to 2 hours, so it's almost double. Are you expecting the same this December? And have you done anything to mitigate it for that time? And the lost hours while they're just waiting, it's still as bad as it was last year. Is there anything that we can do to really improve that so that we're not wasting ambulances' time while they're waiting?
Yeah, I'll try and answer some of that, and I might come to Jim also in terms of that December issue, because I think, again, I think not wanting to try and sort of push away from that, but I think it was a system problem. It wasn't necessarily an EMAS problem. Certainly from our perspective, I think we do a number of things to try and mitigate that. One is that obviously we try endeavour to put out at least the correct amount of resource every day that we should. We often try and go over and above that, and certainly in December that is a natural effort part of the plan to go over and above what we try and go over that 55-60 if we can during December, anticipating that there might be delays in the system elsewhere. So we try and sort of plan for that. Again, I'm going to try to say, because the people who are clearly interested in the numbers and look at the numbers, you're right. Even on a good day of losing 60 hours to hand over, I'll tell you now in simple maths, that equates to 3 ambulances a day. So we're basically putting on 3 ambulances a day to lose at hospitals. That normal loss is pretty standard across the country. We're not an outlier on that one, so I don't want to frighten everybody. But in terms of the numbers, and you picked up on it, so I'm not going to try and dress it up another way. And that can be exceptional on very bad days. So 3 ambulances lost can turn into 10, 12 ambulances a day lost. And I think we tend to convert it into ambulances lost because it becomes very real, doesn't it? That no, these are ambulances you're losing here also. Does that answer your question?
Yes,
Sorry.
Thank you, Greg. Finally, Councillor Wilmot, can we have one question, please?
Coming along today. I'm sure members of this board will be good service. What we contains a lot of information, very newest. Not really huge issues still. Not least the sickness happenings, not least the issues with hospital handovers, risk targets, admittedly on the less urgent end of the scale. Some of the traumatic experience you had to put up with being highly distressing and seems lucky to myself. And as I say, I can take this opportunity to thank the ambulance staff, all those fabulous people that are on this service force, the tremendous work they've done over the past few years. It really is mind-boggling to the very space to do very important. Look at this. Looking at the
Sorry, Councillor, is your microphone on?
I did press it on. Going to say that the overall average hospital turnaround times is very concerning. So many lost hours to the hospital turning. My question is, finally, looking at the staff absence summary, it looks as if you had not got problems. If you had not got problems with anxiety, stress, and depression illnesses, the services would meet most of the targets. And so I just wondered how you're going to tackle this problem area. I mean, have you looked into the root causes? Thank you.
Thank you, Chair. So yes, so what we're currently doing is to look at the root cause for ASD, and one of those things that we're doing is to meet with the staff. Both those obviously are met with who are currently off sick, and we absolutely ensure that they have regular contact, welfare contact, and everything we can do to try and bring them back to the workplace, we do with the tools that we have.
But on the flip side of that, we're also doing quite a big piece of work at the moment where colleagues are being encouraged to come and talk and explain what they feel the reasons are behind some of the sickness and what we could do to support them in maintaining their attendance at work. That's not going to be a quick piece of work because obviously we need to get all those responses together and try and establish that root cause. But there is a massive piece of work currently ongoing and active at the moment to establish what the root cause is and how we can support those that are currently off with better, if you like, with ASD.
Just very briefly, I was going to talk about fluidity and how that works throughout your service and neighbouring services, but that's been answered. The increased population, the increased numbers of cars on the road, how's that impact on your service, your vehicles?
Yeah, thank you. And as you would expect, we do monitor population growth and where it disperses to and the changes that happens. And often as people come into us, get large new housing estates built, etc. So we do monitor those changes, both internally and sometimes we source external expert support in terms of understanding that data, because you can imagine there's an awful lot of data out there in terms of where demographics, where patients live, where people live, flow of people on a daily basis, and as you say, how they travel about our roads. So as an ambulance trust, we do take all that into account in terms of where we deploy our ambulances, where our ambulances are based, how many ambulances we might have a particular site, etc., etc. In terms of busyness of roads, yeah, it is a factor, absolutely no doubt about it. As any Nottinghamshire resident, don't go up Beechdale Road, the main ambulance station at the moment, because it's an absolute nightmare with the roadworks that they're doing. So we do experience that. To be fair to our highways department in the council, they do notify us of major roadworks, etc., and invite us for comment, etc. So they do pay heed to our need. Yeah, it's one of those things in life that sort of comes along. But I think by way of assurance, we do monitor it. It's not something that just happens to us. We try and respond to those changes. Yeah.
But we realise also you're coming close to December and the winter pressures, which we've already experienced before we actually get officially into winter. So I think from this committee, we wish you good luck for the next 2 or 3 months and hope that you can cope and save a lot of our residents. So thank you very much to you all. We're very grateful and realise that you're doing as the very best you can, and that's all anybody can be asked to do. So thank you very much indeed, and we shall see you in September 2024. That seems a long way away, but it isn't.
Thank
you, and have a good Christmas if you're not working over Christmas, but I'm sure most of you are. Yes.
Thank you, Sarah. Appreciate that. Yeah, I appreciate your kind words. Thank you.
Pardon?
I appreciate yours and everybody's kind words, supportive words. Thank you very much.
And to Gemma also. Thank you, because you sort of kept the balance a little bit. Thank you. Thank you very much. Right, we'll just have a minute or two, members. Don't disappear. We've got something very interesting coming up. To actually welcome these guests and also explain what is happening, because it's not quite to your agenda. Good morning, Kim, and good morning, Irene. Welcome to you both. You need your winter woolies on here. It's a little cold. Now, the Vice Chairman and myself have been asking for some time, 6 months or so, to include school readiness onto our agenda. And it seemed to become difficult to decide whether it should be on this agenda or on children and young people. But what we want to hear is not about necessarily a child as a child. It's a child at a nursery. So we figure it came into here. And by coincidence, the Vice Chairman had to go to a meeting at Nottingham Trent University. And the very thing she'd been asking for was was given a briefing at Nottingham Trent University, where they've done a lot of work. Now, on your agenda, it sort of says possible topic for scrutiny. It's a little bit more than that. We're going to listen to Kim, and then I'd like to decide whether we think as a committee we can scope this. If so, form a working party cross committees, so that we can have a look at what has happened, because definitely something has, and try and get these children, these little children, ready for school. Now, Councillor Sam Smith's here today because he looks at the scrutiny on children and new people. Just going to ask him if he just wants to say a couple of words, and then we'll move to you, Kim.
Thank you, Chairman, and thank you for welcoming me to the committee today. And school readiness, as you've set out, is a really important area and something that both you and your Vice Chairman and I have been working on. And it's really important to get school readiness right, not least because of COVID and the impact that's had. My own niece was born in COVID, and the first time I met her was through a window as I was standing on the driveway of my sister's house while they were inside it. And of course, during COVID, things like soft play stopped and health visiting stopped. And what we're seeing now from a school's point of view, I visit schools, I've been into schools. What I'm seeing now is there are focusing hugely now on things like speech and language, training infants to use the toilet properly, sharing skills, because children are getting into our primary schools and infant schools and not knowing how to share because they haven't had that chance when they was born, and the 1 to 2 year olds mixing with other children. Being able to dress themselves is another thing that our primary schools are having to focus on. Writing their name and colouring in, things that are all skills that life skills that are developed preschool. So what we need to do, and schools, as I say, are focusing more on those skills and developing those skills when they enter the door at primary age, rather than focusing on the educational skills that they're there for, and that will, not getting school readiness right, not only impacts on the development of children, but it also takes away resources from our schools and their budgets to focus on catching up on what was missed out at school readiness. So that's why it's really important to get it right. I'm grateful to NTU for coming today and the work Councillor Eddy has done. I've been asking for this to be scrutinised since at least March this year, and I'm really glad to see it on your agenda today. What I think we can do is have you listen to what NTU have done, and as a committee jointly with health and children's and families work together on building on that to scrutinise what went on pre-COVID and during COVID and now, and put forward recommendations to try and improve that to mitigate the risk of, or the impact of schools, but also help the children who are waiting to go to school now. Thank you, Chair.
Thank you, Sam. So it's over to you, Kim.
Thank you for such a comprehensive introduction. That was brilliant. It really speaks to the content of this presentation. So hello everyone, I'm Kimberly Sims. I'm here today to present on Getting School Ready and on a specific initiative that we've worked on within the Oak Tree Lane estate of Mansfield. It's been led and facilitated by my colleague Luke Parmenter, who unfortunately couldn't be here, but he's a real driver of this piece of work, so I just want to make you aware. Yeah, perfect. Thank you. So during this presentation, I'm going to discuss a bit about context, talk about the specific approach we've used around getting school ready in Oak Tree. Then I'm going to talk to you about what school readiness findings we've had. So we've done a really deep listening exercise, and there's been some real outcomes that will particularly speak to lots of the introduction. Talk to you about some early impacts we've had from the community, the school and the services involved, and then talk to you about some lessons that we've learned from, and these are very much from NTU's perspective. So this work specifically speaks to your best start strategy, which sets out how the council and its partners will work together to ensure children have the best start in life, because we know that from research, a great start in life shapes lifelong health, well-being and prosperity. The strategy specifically talks about services working together and involving public and communities every step of the way. Whilst the work here has been done on a small scale in one community up to now, some of the findings are likely to be applicable at the broader scale. And for those of you who kind of aren't aware about the Oak Tree Lane estate in Mansfield, it's in the top 0.01% most deprived areas in England, according to the Index of Multiple Deprivation. So there's a specific context here, and there's a specific reason that NTU have gone into this area. So the approach that we've taken about getting school ready is twofold. We've taken a collective impact approach, which is a structured collaboration focused on common agenda to improve outcomes. And we've worked with collective impact partners across 11 organisations. So from the Children's Centre and Family Hubs to primary school, to parents, to people involved with the SEND, to educational psychologists, to midwives, to GP services, to the healthy family team, to the district council and the county council and the NHS. So we're really taking a very holistic approach to this. And then the second approach we've used is systems thinking. So it's a way of thinking about situations holistically. So looking at a whole system rather than breaking it down into, well, the NHS does this and schools do this and parents are supposed to do this. It's much more broad and holistic, because there we're really finding that there are common themes of the bullet points on the slides of the policies, practices, resource flows, relationships and connections, power dynamics, and ways people are thinking about things that are really complex and important in the way that we're continuing to not improve school readiness or facing challenge in school readiness. So the process is we've done system diagnostic interviews with 11 partner organisations and involved over 20 staff between March 2021 and September 2022. So this was things like coffee mornings with parents, as well as those specific interviews. And we've plotted these against the systems change model. So that's the policies, practices, relationships and connections mental models that I spoke about in the last slide. And then we've gone into some targeted and intentional activity. Now, for the purpose of this board, I'm going to talk to you a little bit about the extensive listening exercise and the findings from there, because I think it's applicable, and then I'll talk to you about some of the impacts that we found in the targeted and intentional activity. So the listening exercise, some of the community findings, I'm sure these slides will be circulated and available to you, and there is more detail available using the hyperlink. What we've found from the community is that there's a real lack of trust between families and services. The community feel particularly judged and a particular level of stigmatisation, and there's been real power of NTU coming in as a neutral party to build the trust and have a level of impartiality, and we've co-produced the findings from this based on the listening exercise. This isn't kind of us coming in and making a judgment. This is what we've co-produced with the variety of partners, and then we found that there are some real practical barriers that haven't been raised. So just kind of want to share with you an example of a story. So the community face real problems accessing their GP appointments. GPs and services feel like, well, if you're from Empty Lane Estate, then you're not attending your GP appointment. So we've kind of looked at it from both ends of the spectrum and said, what's going on? And the problem is that the bus loop that takes the Oak Tree residents to their GP, you can only fit 2 pushchairs on the bus, and the Oak Tree Lane Estate is the last place serviced on this bus route. So if you're a mum, you get there, you've got your pushchair, you're trying to get on the bus, and there's already 2 other people on the bus. You aren't getting on the bus, and you aren't able to make your appointment, and you can't cancel your appointment because you thought you were going to your appointment until you turned up at the bus stop. So it's real practical stories that have really come through from this listening exercise that we've been able to elevate, taking the system thinking and collective impact approach. And we've talked to Councillor Smith talked about the impact of lockdowns and that isolation, less face-to-face support, and home learning environments have been particularly challenging. But this is in a community already experiencing challenge that was exacerbated in lockdowns. But these challenges were already there prior to lockdown and COVID happening. And the community, a real sense from the community is they're tired of projects coming in aimed at saving them from themselves. What they were saying, and I thought that really resonated with us, and it's really resonated with the partner organisations. So then I'm going to share with you some service related findings. Our referrals to services are particularly laboured, they're insensitive, so people will speak to one organisation and say, I've got this problem, and then they're going to have to disclose problems and have the same conversations multiple times with different organisations. And forms and data come up a lot, and repeated telling of stories is exhausting for the community. And they're constantly having to fight to get access to referrals, and they either do that and try and make some progress, or the children with needs aren't effectively identified or helped. There's an erosion of the connections between services, so data sharing is a particular barrier. There's little collaboration and no cross-sector partner network. So we're not collaborating across different organisations, but then also within COVID, we're not collaborating and communicating within organisations as well as some of the findings that we've had. Services have got unintended competing goals that are impacting their family, so they'll have one person come in to talk to them about stopping smoking, they'll have another one come to speak to them about obesity, and they'll have somebody else come and speak to them about attendance, and it just feels quite complex from the point of view of the families. And this is really important because the Best Start strategy talks about the need to work together, and how all of what I've discussed manifests is that school-aged children are coming to school not ready to learn. So Councillor Smith talked about children coming to school in nappies, children coming to school not able to communicate effectively, and it's not just about what you traditionally imagine, that, you know, can children play effectively together, can they follow instructions? It's across the whole piece. There's significant challenges within health and well-being, social, emotional and mental health, communication and language, and their physical development. And if I talked about Oak Tree Lane Estate in this specific example, in 2020, 24 children began the foundation year in that primary school. As per school procedure, a mixed method assessment of their levels of readiness was conducted in the first few weeks of term. Of the 24 children who undertook the assessments, 22 were so far behind the expectations required for children to thrive at school, they were unable to complete the assessment. That's 92% of children in that state not able to even meet the baseline of the assessment. And that, for us, as I'm sure everybody in this room, really speaks to a huge problem. So now I'm going to talk about what we're doing about it. So we're using collective impact as a co-designed and co-produced framework for change. We're working with our service partners to have a common agenda. And the common agenda are these 5 bullet points at the top on the indicators, so better connections between services and then the ones underneath that. These are the real problems that we are trying to solve within the Oak Tree Lane estate. And I think there's some commonality. We were talking about replicating or upscaling this, but there are some specific things here within the Oak Tree estate. We're talking about we are having a shared measurement system focused on early learning goals, uptake of services. So all of the services are speaking to a common agenda. We're doing mutually reinforcing activities. So we're not all trying to effectively kind of engage on our own particular focus. We're trying to support in a more holistic and collaborative way. So we've developed it's called Routes to Readiness. It's a document which details what key milestones are, what parents can do to support at home and then their home learning environments, and what services are doing for children and families at different key points. So it's really clear and really explicit and all in one place. We've got continuous communication between partners to maintain the momentum of this. And as NTU, we're providing what's technically called backbone support. So it's about convening partners, facilitating, collecting and monitoring data, and identifying and winning some funding. We just want to talk to you a little about some of the systemic challenges that we're finding within this. And I've really put the child at the heart of this because I think it's particularly important. So our parents and carers and families are lacking a clear understanding of what they can do to support child development, and there are inconsistent home and home learning environments. But it's not all about the parents being the problem, and it's bigger than this, and it's about systemic barriers and systematic problems. The school are experiencing unexpected children arriving on day 1 at school. The reception class year is spent getting ready to learn, and that has huge impact on their progress. Services are finding non-attendance at activities and programs challenging. So if people don't attend, they assume that people don't have a need for it, and it's that kind of use it or lose it cycle. And there's a frustration around access to service and lack of signposting. And within the community, there's some really unfair and unhelpful stereotypes, and it's a community struggling to thrive. But we've really found that discussing those stereotypes in a neutral way has been really positive for moving forward. And on to our most important finding, and this has taken a lot of Luke's work to build the trust and develop the relationships. And I'm not going to undersell how challenging this has been, but there is significant energy within the communities to support and lead the change. There is a real willingness to engage with services, shape the support provided by services, and design in a collaborative way. We've got peer supporters from the community who are giving up their time to deliver peer support, and people are really prepared to give their spare time to improve the system for others to benefit from. And there's a really strong desire to build a resilient community and see their children thrive. And then I'm going to talk to you a bit about our impact. And I've divided these into 3 slides. So talking about the impact for the school, the impact for the community, and the impact on our services. So within Oak Tree Primary and Nursery School, they've gone from inadequate in 2018 to good in all areas. In 2023, they were described as the worst primary school in the county at one point. And getting school ready has been cited as an enabling factor. We've had really positive outcomes in reading and phonics. It's been the highest ever, and we've been able to bring in funding to support specific groups of children, and we've seen a huge increase in parental engagement. Within the community, they've developed, I'm saying we, it's absolutely not us, it's they have developed a parent-led stay and play, and we've got 2 health and wellbeing champions next slide, please, Noel, sorry. And a re-emergence of adult education within the area. And the parents have developed a summer calendar of events. Now, this is stuff that in some areas is standard business as usual, but in this area it really wasn't, and it's taken a huge leap of faith from the community and a huge garnering for them to kind of want to come together and develop this, and that's been really positive. And they've developed a warm welcome group, which is a place where they can all come together free of charge, have a warm drink and discuss kind of parenting, get together as a community, and that group's now become constituted so they can access funding. And then we've had big impacts on professional services. So within the area, we've now got a vertical cross-sector partnership. We're working with players from the County Council and Mansfield District Council, and people working specifically in the local area as well, so across geographies. I've talked about our routes to readiness documentation. We've been able to bring in people to talk about systems leadership programs, so all of the service partners kind of we're all on the same page with what we're trying to do, and we're all speaking a common language. Educational psychologists have been really positive and have been brought into the primary school and to work with the children, and brokering of relationships with residents has happened within a range of different services, and this is vital. And there's a willingness all around, I think, what we found, and awareness of issues. It's just been quite hard to actually do it and quite hard to actually make a change. And the systems thinking and collective impact approach has really, I think, helped provide a structure for that. So my final slide is about the lessons that we've learned. So there's a real appetite for change. It's helpful to have a structured approach and a common agenda that talks about systemic and structural issues, and it's not about a blame or a deficit model. We're having meaningful, authentic engagement, and that's really essential. Committing in the long term has been really positive. The relationships are key, as you know, with any of this kind of community change activity, and it's required flexibility from all partners, actually, in terms of valuing diverse perspectives, thinking about, well, what are the barriers that we're putting up as service providers, and how can we change and work effectively together, actively avoiding judgment, and us coming in with a level of neutrality, I think, to sort of shine that mirror and get people to speak to each other effectively, rather than them feeling blamed and that something's not working, and that being a very personal message. So we've been able to provide a level of impartiality, and that's my presentation. Happy to discuss.
Well, thank you, Kim. That was a very quick brief on what you found. Just one question to ask you first. Where are we in the cohorts of children now? Because obviously the little nursery schools have started up again. So how many years are we actually looking at? 1 year will have gone to school, and that's how it's been found that they weren't ready to go to school. So are we looking at 2 years of children, or just one now?
I think in terms of the Oak Tree project, it's looking at all the children in that community. If we're focusing on school readiness, we're focusing really from conception onwards. So I think the Oak Tree project is, you've spoken to the parents, most of them have school-aged children, so they are in reception year.
So it's higher up the school as well. Okay. So how can we help you, Kim? Because that is, as I understood it from the Vice Chairman, that Luke was asking for some help in to try and bottom out what is happening or not.
So we're currently at the point of thinking, how do we expand beyond Oak Tree Lane Estate? How do we either replicate the project or scale the project to demonstrate impact at a broader level? So thinking of probably across like Mansfield District, for example. And we have got some funding bids in at the moment. And our questions, Councillor Eddy, came from, has anything like this been done in terms of a cross-sector approach to something quite specific? They're getting school readiness, but they're kind of getting learning readiness. And if so, what has that looked like? What would that look like from your perspective?
Okay. Councillor Smith.
Thank you, Chairman. Kim, thank you again for that presentation. I think on the slide 10, I think it is, when you mentioned the most important finding was that communities are willing to engage and help deliver the support. And then going back to what you said earlier about transport, which I would never think of, is, you know, there's only 2 bays on a bus, and how do you get buggies on, etc. I think where the council can help, it's really important the work you're doing, but it's important that as a council we focus on what are in our levers we can pull to respond to the factors that you've highlighted. And I think one of those responses, is public health and what they're doing with health visits, which we can scrutinise, but also the rollout of family hubs, which again is something that this council's doing. And I know there's one coming to Oak Tree. And what family hubs basically do is take all the services that you get on a bus for and put them in your local village hall or town hall or community centre. And we're rolling them out. There is one coming to Oak Tree. But I think what we can do as a health scrutiny committee and a children's committee is look at that lever that we've got to help mitigate the stuff you've highlighted, but also scrutinise health visiting as well. Thank you.
Right, Councillor Callaghan.
Oh, nice to meet you. Working in Oak Tree for over 30 years with children and families, I just do want to bring this back to 2020, when our leader and our MP didn't do himself any justice or any fairness to the residents of Oak Tree when he talked about crack dens for using free school meals and vouchers. That has stigmatised and actually disincentivised any parents to work with agencies. In Oak Tree, as you know, it's probably one of the only schools in the county with a social worker, because it has 75% of its children under a social worker. As you know, we have quite a few illiterate parents. How has anybody tried to work with those parents? Go to you, Irene. We have a children's centre directly across from the school. Never worked together. You know, it's just unimaginable that, you know, if I ran a parenting programme there and I had children in the creche, the children's centre wouldn't have the kids in the creche. I had to then ask the school, can you provide a creche for me to deliver parenting programmes? It wasn't working, and it's still not working today. My daughter-in-law actually works in Foundation at Oak Tree. She's worked there for 18 years. So I know all about the deprivation and the challenges, not only to the school, but to the families as well. And we've got lots of that. And I think, coming back to the hub, you're dead right there, but it's about working together, because we still have silos. We don't work together. We don't do early intervention. We are crisis managed. And I think we need to get in there. And yes, the pandemic hasn't helped us, but we know before the pandemic, you know, we need to invest more into children, into the early years, because that is the crucial time for these children's learning. If we don't get it right, and obviously you haven't put your spider chart up there, but when you look at, you know, the dentist, the education psychologist, the speech and language, it's not there. It's not enough there to put what we need to see the improvements going forward. And I can only say, hopefully, a family hub, because we missed it the first time round. So I'm actually looking forward to a family hub being up Oak Tree and seeing some collaborative work, because for a long time, lots of residents, especially the parents, have been stigmatised and blamed. We're not in a blame culture, or we shouldn't be, but I think we still do that, and we do it really well. And I think we need to turn that on its head.
Right, thank you for that. Irene, did you want to speak? You look as if you do.
Well, I don't have to do it. I mean, I think Councillor Callaghan, you do know the area very well, and it's really useful to hear that feedback. There have been there was a big partnership event on the Oak Tree estate a few weeks ago, I can't remember now, it's all a blur, where lots and lots of partners came together. And certainly in terms of children and families, there's a huge willingness to work with all those partners coming together, and family hubs will be one of those outcomes. But you're spot on, it's about relationships on the ground, it's about building that trust. And I think, you know, with MTU helping and being that independent provider in the area, it has been really helpful to bring those people together. So onwards and upwards, we hope.
Thank you, Irene. Councillor Turner.
Just a quick comment, really, that issues with young children are not exclusive to areas of deprivation. This is from personal experience. I have a 4-year-old granddaughter who was born COVID times, and my daughter was experiencing issues with my granddaughter. So it's a bigger approach required than just looking at areas of deprivation.
Councillor Hollis, am I correct? You wanted to speak?
Yes, really, yeah. I think obviously with it being an unusual item for this committee, I think I appreciated the words to introduce it, because obviously we don't want to get crossed over with the children's department and confuse matters. It's the whole purpose of having the scrutiny process in the first place, so we know where everything is. But I think that said, I will welcome any opportunity to talk about children's issues, and colleagues around the table won't be surprised to hear me say what I'm going to say. But I think particularly words of thought for Anne, Councillor Callaghan particularly. Obviously, we were promised one member of these hubs, and exactly as outlined in the report from the NTU colleague, which I appreciate the presentation. Thank you. I wish I could talk as fast as you. You know, it'd be wonderful. I'd get so much more said. It was it's a skill we admire. You know, big tips, but the family hubs, of course, were promised and not delivered. You know, at Huthwaite, we had a purpose-built family centre, which was to design exactly all the stuff that I'm looking at in the school readiness programme. And of course, Irene did some great work there. We were completely abandoned by the county council, who threatened to pull every single penny. And it was only through some last minute work, I think, from colleagues in the department that managed to get enough scraps together to give to the school just to keep the lights on. But we've got a purpose-built soft play cafe. The entire facility was built to the standards of a Sure Start Centre and family centre, and we were abandoned. Our family hub was proposed to be at Hucknall, never happened. We haven't got one for Ashfield, and I think it's disgusting. And while I welcome what's happening here, I think it's rather like the £20 million given to the government, given by the government to Kirkby and Ashfield. You know, they take off £15 million a year for the district and then give us 20 million over 20 years. Doesn't stick a plaster on the already cut wrist. But that's what I hope. I really hope it works in Mansfield, Councillor Callaghan, and I hope the county council will actually do what they originally said they were going to do and roll this out amongst everybody. And I think what Councillor Turner said was also very important. It's not just areas of deprivation, but of course that's where it hits the hardest, the most, whether it be lack of transport, whether it be lack of pure finances, or even knowledge. And while I hope to be a parent soon myself, none of us are born with the knowledge of being a parent and what it is to look after a child, and actually having some community and learning and shared experience that these centres provide, not only for the family planning and bringing up, but also for the schools and future life. It's all important, and it's no surprise that we see Olympians all coming from privately educated and public schools rather than community schools, and it's no surprise that we see health, entertainment, every record you can, all skewed to economic base, and that's what these centres, in my mind, have a way of levelling the playing field. And I struggle. I'm pleased, but also disgusted in the same breath. Is this shouldn't be just in a one place or one thing. It should be rolled out everywhere. and that's why I want to end with a thank you to you, Chairman, for actually bringing this. I think probably tongue in cheek, forcing it into this committee's agenda, because actually it should be spoken about. And I think hats off to yourself for raising it. So thank you.
Thank you, Councillor Councillor Fowle. Sorry. Would you like me to answer that?
I'm glad we're having this discussion, but it just feels very odd that it's arrived on this agenda so quickly and so now. And you say about scoping it, Chairman, and I understand why you want to do that, but we cannot do justice to this here now, given the fact that we've got hardly any data, hardly any warning of this. It's a huge, complex project. And it's absolutely immense. And I just think, why don't we stick to the work programme, that we've got the stuff on this work programme? You look at mental health services and support in schools. Our children are in crisis in terms of mental health. They're an absolute crisis. And this is yet to be discussed, yet to be kind of brought forward to this committee. You've got nothing in on February. Why isn't it on the February agenda?
Let me answer your question. I think at the beginning I said that we had been trying to get this on the agenda for 6 months. For one reason or another, it wasn't allowed to be put on because nobody could agree whether it went to children or whether it came here. We were quite convinced it should come here. Councillor Smith said it should come here, but I'm afraid we've had some problems trying to get it on an agenda at all. You tell me, nothing to do with me, we've asked. Now, if, as you suggest, we don't discuss it at the moment, we've just heard that it's right across the board, but it's also very important that these littlies that are about to start in September are helped now. If we delay this anymore, they're going to be at school in the same state that we know the ones are at the moment, who can't even hold a pencil, can't imagine to tell a story. And so how long do we delay this? We've been trying for 6 months to get it on this agenda, because it was advised that it went up to Councillor Smith. Councillor Smith said, no, you do it. We have been asking and asking, because it was through Councillor Eddy that this all came to be. She had been to Nottingham Trent University, and also she has experienced this with her own daughter, who goes to play school, playgroup, play school, and she's finding that her daughter, who she has taught, can do things, but the other children are just sitting, not knowing what to do. So, okay, we could have this on the work programme and bring it up in February and decide to start a working party. Easter comes, Easter recess, so we get to May. And before we know where we are, the children are at school. And we're trying to move this as quickly as we can with Nottingham Trent University to try and help schools that have got issues. Now, there'll be a lot of schools with issues, but there'll be many with deprivation. And if we can hit those, then we're doing something. Councillor Smith wants to come in.
Thank you, Chairman. Just to build on that and for Councillor Fowle's information, I held a chairman's briefing of the Children and Families Committee officers and myself in March. I made it absolutely clear in that meeting that if school readiness came to the Children's Department and Children's Scrutiny Committee to review, we would be, and I would expect my members of the committee to focus questioning on the impact school readiness not happening is having in schools at that day that we're meeting, i.e. the resources being pulled away from learning and the curriculum to actually teach children how to hold a pencil and how to use the toilet and how to speak and imagine, as the chairman's just said. And that's the questioning focus that would come from, rightly so, from the Children's Committee. Now, from a health point of view, the questioning is about what can we do pre-school through the health colleagues to mitigate it getting to that point in schools. So there'll be doing it separately in two different committees. There'll be two different outlooks and two different lines of questioning, quite correctly. What I said in March, I've got the date somewhere, and it was 4:06 that I gave the instruction. I looked at the notes today. Was let's do that collectively. Let's do it as one working group, but let health start it off, i.e. let it get on the health agenda to trigger the working group. And I gave that instruction absolutely clearly in March. I don't know why it's taken this long, and I'm sorry it has, but Councillor Saddington, Councillor Eddie and I have been working really hard in the background to make that happen, and we're here today to make that happen. So I think if we didn't do all that, you and your colleagues on the opposition would quite rightly be questioning us as to why. And now it's on the agenda, you're asking us why it's on the agenda. We've worked really hard to get to where we are today. We need to trigger the working group and get on with the scrutinising to build on NTU's work.
To say to you, if you were talking about this 6 months ago, Chair, this should have gone to overview and scrutiny then for scoping. And then I think it would have moved on.
I think
that's the proper process, not to dump it on this agenda at the last minute.
As Councillor Smith has just said, that is what we have been asking for.
It might help if I give perhaps a little perspective from my service area. In March, you will recall, Councillor Fall, and as will everyone in the committee, that this committee considered the Healthy Families programme, and included within that was the health visiting service. That was a subject that was the subject of some discussion as to whether and where that would be discussed in full, and that was eventually resolved. Now, the discussions that took place in March, from memory, the issues about school readiness were front and centre of a lot of the discussion that took place here in this forum on that. And I'm afraid with the benefit of hindsight, it may well be that I conflated the discussions that took place in March with this forum considering school readiness. And I think that's perhaps where the confusion has risen. And I'm genuinely, at no point had I put school readiness formally on this agenda. And frankly, I did not pick up that is what I was tasked to do. However, we seem to have fallen between two stools in terms of how the process of actually driving this work forward. And so if my part in that was to confuse matters, then I offer an apology that we haven't seen this more recently. But it wasn't work that I had in my inbox that I wasn't dealing with. So I think that's sort of where we are, and we've had to recalibrate in perhaps a rather clunky way on this occasion. But what we now have is a situation where the issues are in front of us, and there's a desire to deal with it as quickly and as efficiently and constructively as we can. So from my own point of view, that's my perspective, and I can only hope that we can, from this point, move forward constructively to deal with the thing as best we can.
If I can just come back on the issue that we had, which was we had it earlier in the year, and we had a discussion about young children going to school. It was not what Councillor Eddy wanted. We wanted something like we're having a presentation from Kim. And we have been trying to get the people to come and talk to us. It was sheer coincidence that Councillor Eddy went to Nottingham Trent University, met up with Luke and Kim. She came back to me and she told me, and I said, right, it needs to be on straight away. But we have been 2 or 3 months, 2 months, I suppose, trying to get it on the agenda. But it is on, and we will deal with it, and we will help these good people to move forward with it, because there is a crisis out there and it needs to be dealt with. But if we mess around for months, we've got Christmas coming, nothing happens. If we mess around for too long, there'll be no workshop sorted and we'll get absolutely nowhere. And these littlies will be going to school, still not able to hold a pencil, still not able to go to the toilet. So we need to move it forward. Anybody else got any other suggestions? I'm coming back to you then, Councillor Smith and Vice Chairman. Oh, Councillor Wilmot, do you want to go first?
Oh, thank you very much, Chair. Just to say that as far as what's been spoken about today is a breath of fresh air to me, because I've been talking about early intervention for a long, long time. At the moment, I'm seeing a lot of homeless. I'm seeing a lot of people involved in domestic abuse and sexual violence, taking drugs and drinking excessive alcohol. And all of them have the same problem. At an earlier age, they've not been educated into being able to stop themselves from doing these things. So for early intervention, preschool, children's centres, education in schools as well, all needs to be expanded, needs to come together, working together. Let's have an organisation with everybody involved, so that we can sort out these severe problems and make sure that our children have a good start to life and don't get into these problems that I'm seeing at the moment. Thank you.
Councillor Martin.
Yeah, I'm sorry, but I'm a bit disillusioned here. So I feel a bit like I'm in the dark ages after the Romans left, because we had a system across the county that did exactly what Kimberly's talking about, right? Sure start centres, they were all cut back. They've all been cut back. They were the ideal conduit where midwives and health workers and doctors and all sorts of other educational processes happened at these centres all over the place. And the previous administration took them away, and then they went to a hub system. What good is a hub in Hucknall to my residents in Chester? I can't get there. Councillor Hollis had a sure start centre in Huthwaite, a highly deprived area. Stanton Hill's the same, right? And Ashfield and Mansfield in particularly ranked in one of the highest deprived areas in the country. We had a network that was set up in 2010 called Sure Start Centres, and that's where the health workers went, and they had all sorts of drug, postnatal, everything that went off in there. That was the ideal conduit, but it's been cut back. So I feel like now I'm sitting here reinventing the wheel, and that's exactly what I feel like. And it's right, just wrong where we went, and I think it's about time the county council recognise the fact that they've taken something away, and now you've got a crisis on your hands.
I don't know that it was actually the schools, the places that you're referring to is what actually Councillor Eddy had in mind. She's going to speak next, so she'll tell you. But I can remember taking my grandson, and we're talking of he's coming up 15, so it was before the COVID. But I used to take him to a place once on a Friday, and we used to dance around, sing around, do little things with hands, learn things, learn songs like the wheels on the bus and this sort of thing. These children don't know this, but we weren't going to a centre where there were midwives and all the people that you're suggesting. It was a centre where a lady was actually teaching children songs, doing things, picking up things and learning what a little stuffed toy was, this sort of thing. That is what didn't happen during COVID, because these places had to close. So you're talking about Sure Start. I'm talking about something a little bit different, And I'm sure Councillor Reading is talking about them both. So would you like to explain?
Yeah, but at Shore Start Centres, that's where they taught them to toilet train them and sing those songs and do all that kind of stuff that you're talking about. In my rural area, I had to have private blooming preschools. That's what we've got, funded by government funding. I've got a charity, All Sorts Playgroup, has been running for 35 years in Underwood, and in Southton, in the Tin Hat Centre, we had a Shore Start Centre where people could walk to it, because none of my residents would ever get to any hub in Hucknall, none of them.
Right, Councillor Reading, would you like to put your points forward?
Thank you. This is really important to me personally. I've got a 4-year-old who'll be starting school in September. And for those of you who weren't parents during lockdown, it was awful. You know, it was lonely. It was my daughter was going to nursery and they were having masks on. There was no activities. I think we even tried to do an online sing and dance thing, and she fell asleep because you can't, as a 6-month-old, understand, can you? She thought my mum lived in a phone, if I'm honest with you, because everything was done by, you know, video call. So for me, this is a really important piece of work, and it just so happened I went to a presentation that Nottingham Trent University did, and although it's about that, that's a specific issue for Mansfield. This is, for me, countrywide, county-wide, because there are children that are going to be going to school in September that have really suffered, especially during lockdown. So although it is about the services, it's, for me, in September, there's going to be children that have had lockdown that haven't had the same upbringing as a lot of other children because of their situation. And that's something that I'm really, really passionate about, trying to improve specifically that cohort of children, as well as all the children. But I do feel there is a specific issue for the children that are coming through now, that like my daughter, who genuinely, you know, it was just a bizarre time. And if you didn't have the services, you know, it was baffling, really. So for me, that was where I was coming from with this, that it's a service-wide thing that we need to look at, especially for the young children that are affected by COVID, because my worry is they go to school in September and we've not done anything extra to alleviate the fact that they've got the interpersonal issues, they've got the speech and language, you know, because people are wearing masks, and basically they were in their homes there for months at a time. So that for me is where I'm coming at from this, and I really hope that between us all we can set up this working party that looks at the not just things that have been cut and whatever, that we look at the children that have been affected by COVID, but also how we improve it for everybody in the county. I think that's where I'm coming at it. So it's not necessarily, it's more of a personal thing for me, I suppose, because of my little girl going to school in September. But that's sort of where I was coming at it when I've been trying to discuss it with colleagues.
So, members, where do we move from here? Councillor Smith, what are you
Thank you, Chairman.
suggesting?
My proposed scope is that we have a joint working group between members of the Children and Families and this Health Scrutiny Committee. We get the health visitors in and talk about their work pre-COVID, during COVID and now, and we can assess the differences there. We can then talk to the Children and Families Department, particularly those on the education front line, and hear from real world people in infant schools and primary schools about the impact, particularly that COVID cohort having on schools. As I mentioned earlier, they're focusing more of their resource in catch-up duties rather than the education curriculum. And then talk to the team who are in charge of the family hubs and come to your point, Councillor Martin and Councillor Hollis, about where those are being rolled out, what services they're offering and how they can help with the catch-up and the COVID cohort, and then put forward those recommendations to the relevant portfolio holder and portfolio team to try and drive that improvement. Particularly, obviously, it's important for the children going in September, but all those children that have come after that, because they're all impacted, and bringing the families along with them, which Councillor Callahan quite rightly said. So that's my proposal. Councillor Eddy may have something to add to that.
I think that, to me, is the most sensible way forward, that we bring in everybody that we need to speak to. It's not just a one committee thing, in my opinion. And I think we really need to all work together. Otherwise, we're not going to improve it for any of them.
And I just add, sorry, I should have said, I did say it in answer to Councillor Fall, but the importance of having both children, families and health together means you can look at it as a whole view of the impact of schools and the impact of preschools from the health perspective as well.
So members, do we agree with this idea first before I take it any further? I think we probably do. Councillor Callaghan, yeah, Councillor Fall, Councillor Martin does. Right, let's move forward at a pace because time is the essence. You know, I don't mean today, Councillor Callaghan. No, I mean, we have very little time before we go into the new year, and I think the new year really will be the turning point for children thinking about school. So I am going to see who'd like to be on this. Councillor Smith, would you like to be chairman of this workshop party?
I'm happy for Councillor Eddy to be chairman, but if you
and have Councillor Eddy as
chairman, she can chair. But if we take
both do it together for me or whatever.
Take a view of who wants to represent your committee, I'll then write out to my committee members and ask them for volunteers.
Yes, we need to get members of the committee. I mean, it's by coincidence Councillor Callaghan's here today, but you mentioned Councillor Henshaw, didn't you? Pardon?
Gan needs to be on the committee, but if you want another member from Labour, I probably need to ask.
Yeah, I think we will leave it for the officers to deal with it as quickly as possible because here we are. And I'm sure you as a group, we as a group will think of schools where we need to tackle and come up with the ideas that Councillor Smith has put forward, and let's get moving with it. Are we all in favour of this? And this is the reason, Councillor Fowl, it has been brought forward because there's been enough discussion and getting nowhere, and we insisted that it came. Okay? Pardon?
As long as the working party isn't just discussion too, because that's certainly my experience of the cost
No.
of living one.
I think Councillor
happening.
Councillor Eddy is very much wanting this to go ahead. Councillor Smith wanted it to go ahead earlier in the year. The two of them will pull it together and we will have a result, hopefully, by the summer of the way forward. This is for the littlies. And then, of course, we need to be looking at the older children who are still in a dip. Now, whether you want help from Kim, probably, and in the committee, you, as far as I'm concerned, can pull it together. Councillor Callaghan.
Councillor Fowl said earlier, and you've just alluded to the older children as well, I do think it is imperative that we put children's mental health on
it is
the
on,
work programme
for
February.
Yeah,
to bring that forward, because it is a big thing with CAMS and everything else. And we're talking about children's emotional and social inability to form friendships and peer interactions or imaginative or creative play because they've not been stimulated to be able to do that.
Absolutely.
We've got February meeting's got nothing in it, so in February.
We are looking look at mental health. The other thing is Councillor Eddy, I don't know whether Councillor Smith will come to our meetings, I'm sure he'll be busy in other things, but Councillor Eddy, I think each meeting, not December, but I think she'd be happy starting in the new year just to have 10 minutes of an update of where the working party is getting to, so that those people who are not on the committee will get some review of what's going on. Not a big briefing, just 10 minutes. And yes.
Yeah, I think we need a representative from public health on the committee as well, because postnatal depression was one of the greatest things that Short Talk combated.
We'll talk to Councillor
and further education.
He doesn't know about
and other services like sexually transmitted disease and all that kind of stuff.
So we're all happy with that. The officers are going to take it forward ASAP, and members will be asked if they want to join, and please join. Please move it forward. So that brings up the work programme we have somewhere. We've been asked to put the mental health on. Put mental health on, please, for February. And we've got, where are we? December. Yes, we've got the urgent treatment centre at Newark coming up, and we've got tomorrow's NUH December meeting. We'll try not to make it too long. So with that, members, I'm going to close the meeting. I see a lot of energetic looks as if you can't wait to get going, so that's great. Could we turn off the live stream, please?